Okay, let's get started. Hello and welcome. Thank you for taking the time to join us today. My name is Kylie Lance, and I work in the Center for Health Equity and Community Engagement Research at Mayo Clinic. I want to express my great appreciation to the American Indian Cancer Foundation and the American Cancer Society for coming together for this collaborative event, and for our strong partnerships as we work to find solutions to the health inequities our communities face every day. Today's event will be facilitated by the delightful Coco Villaluz. She is the Health Equity Manager for the American Indian Cancer Foundation, and I'm excited and grateful for her presence today, as well as all of our esteemed panelists. This is Getting on Track with Cancer Prevention in a COVID-19 Era. Coco, take it away.
All right. Thank you so much, Kylie, and welcome everyone. We are so honored to have you here with us today in our virtual circle. So with that, I just want to begin. Hayakanawashde, Hafide, Chazemitawa, Enisakumaki Makiapi, Tobecha Wachwa, Enwati. As Kylie said, I'm Coco Villaluz, and I am tuning in from the ancestral homelands of the Nakota Dakota people of what is now known as Northeast Montana on the Fort Peck Reservation. And we're so happy for you to be joining us on Getting on Track with cancer prevention in the COVID-19 era. And we definitely understand we have all been through a journey with the global pandemic and how this has impacted us as individuals, our communities, and the work that we do. And so it's such an honor to be able to introduce you to this esteemed panel of colleagues here to, really give us some in-depth information. And we have Dr. Laura Makaroff, Melissa Buffalo, and Dr. Katherine Price. And we will also have a story from Crystal Lammers, and we'll get into a little bit more of their bios as they get ready to present. Just a few ground rules. We'll have time for questions before we wrap up. So please utilize the chat or the Q&A functions during the event, which is at the bottom of the screen. We will also pose these questions to the panelists before the end, and we'll also field any unanswered questions following the event via email response. So with that, I would love to introduce to you Dr. Laura Makaroff. Dr. Makaroff is a family physician and Senior Vice President of Prevention and Early Detection at the American Cancer Society. She oversees a broad portfolio of cancer prevention and early detection initiatives, including health equity, cancer screening, HPV vaccination, tobacco control, comprehensive cancer control, and other national partnerships. So we would love to give a warm welcome to Dr. Makaroff to really provide an overview of cancer prevention and screening. Dr. Makaroff?
Great, thank you. I was muted. Let me get my screen situated here so that I can look at you all and see my screen, which is a little bit tricky. It's okay. I'll just look both places. This is save time, but it's so nice to be with you all today. Thanks for joining. So I'm here with the American Cancer Society. I serve as Senior Vice President for Prevention and Early Detection. I'm a family physician, as Coco nicely included in my intro. I just want to talk to you a little bit about kind of like what are we thinking about when we think about cancer prevention, and then what have we seen as the impact of the pandemic, and then what can we do in our daily lives to help improve our own healthy behaviors so that we can help reduce the risk of cancer in our own lives. So with the ACS, we have a tripartite pillar strategy that includes what we do in our advocacy arm with Cancer Action Network, what we do in our discovery arm with our research program, and then what we do in patient support, which is what I do here at the ACS. So to set the stage, what you can see here, this is our cancer facts and figures from 2022, and a little bit of a teaser that cancer facts and figures 2023 will be out, I believe, tomorrow, or at least later this week, so you can look for that. But this is our kind of annual report on like the status of cancer in the United States. We do some global work too, but this is the United States. So as you can see, we're anticipating about almost 2 million new cancer cases each year, about almost equal males and females. You see the breakdown there that prostate is the leading cause of cancer in men, breast the leading cause of cancer in women, followed closely behind by lung, colon, and then some breakdown from there. Now, importantly, this doesn't mean that all people are impacted in the same ways. And so this is really just kind of high level look at what this looks like when we break down by race and ethnicity. The other important caveat I like to include on this slide is that these groups are really pretty not homogeneous, meaning diverse groups. So you have to recognize that even within this breakdown, that there's a lot of variation and difference in populations and communities in the way that each individual person and their family and sort of network around them is impacted by cancer. But importantly, the important takeaway here is that cancer incidence or the risk of developing cancer is not equal across all races and ethnicities. And you'll see that the population impacted the most is Black, followed closely behind by American Indian and Alaska Native. If we switch to think about cancer mortality or the people that are dying with cancer in each year, here's the breakdown here. So lung cancer is the leading cause of cancer mortality by a lot for both male and female, followed closely behind for prostate for men, and then breast, and then colon, pancreas is up there, liver is up there, and for males, and ovarian and uterine is up there for females. But you'll see that the major leading cause of cancer-related death each year remains lung cancer, although we see many, many new advancements and new therapies, targeted therapies that are helping address this large impact of lung cancer. So that's very, very hopeful and promising. Same story with the disparities when we look at death rates broken down by race and ethnicity, is that it's just not equal across populations. And we see disparities happening for lots of different reasons. A lot of that is not necessarily grounded in the disease state, but is grounded in the environments and communities and systemic racism and other issues that our communities are facing kind of across the nation. So we have lots of work to do to help address these disparity gaps. So thinking about where does cancer prevention fit when I think about the cancer continuum. So if you, this is just a quick kind of graphic to describe what we're talking about when we think about the cancer continuum and where cancer prevention fits. So cancer prevention is really on that sort of upstream side. And we think about prevention, which hopefully then includes early detection of cancer if a person is impacted by cancer themselves. Treatment support within that, the research that goes along with that, and then of course supportive care and or palliative care that goes with a cancer diagnosis, leading to survivorship in the long-term space, or sometimes people as they're facing end-of-life and bereavement. This is the cancer continuum as we see it at the ACS, and the work we're doing to help make a difference across the entire continuum. So the pandemic has had a lot of impact on all of us individually, and certainly has had a big impact in cancer. So this is a graphic from a couple of years ago now, actually, but I think it's still true today and helpful to think about the impact of the pandemic across the continuum. So certainly when we think about just our own lifestyles and things that have changed in our lives through the pandemic, that matters to the prevention side of things. Preventive care and or care for an active cancer diagnosis has been impacted and was really significantly impacted at the beginning of the pandemic when people needed to postpone or cancel or sort of stop kind of non-COVID related care. That was because people were both reluctant or maybe fearful about going in for care, as well as healthcare systems really needed to adapt and make pretty significant changes to just manage and deal with this new pandemic and how sick and urgent, how much urgent kind of emergent care was needed for the people impacted by COVID. So just to say that the pandemic has impacted really all parts of the continuum. When we think about screening, this is some look at a paper. This paper was published like early last year. So I think we're still waiting to see the real full impact of the pandemic as time goes on. But what we know is that cancer screening took a big hit at the beginning of the pandemic because of the reasons I mentioned, both because the healthcare system just couldn't manage prevention or screening parts of their daily workload, as well as because patients became, concerned or afraid to go in for kind of their routine care. So fast forward to the beginning of last year, and this is what it looks like through 2021, that we still were seeing some significant decreases in these cancer screening types because of the pandemic, and needing to really kind of continue to recover and help people get back on track with their cancer screening. So let me talk a little bit about the kind of the case for prevention early detection, and I'm talking, about what's prevention and what's early detection, and then what that means to managing risk of cancer and helping find cancer earlier when it may be easier to treat or treatments are more effective. So when I think about this, I really break it down into sort of modifiable risk factors, things that people can do something about, things that I can do something about as a clinician, things that organizations like ours can do something about. And then there's some things that are non-modifiable, or things that we're just born, we have certain genetics and all of those things that can increase risk too. But let's focus on the modifiable risk factors. So modifiable risk factors are things that happen in our lives that we can do something about, or you can get support to do something about. So that includes cigarette smoking, excess body weight, physical inactivity, an unhealthy diet, and reducing alcohol. So all of those are part of maintaining a healthy life and reducing the risk of cancer. The early detection of cancer, which comes through cancer screening and cancer screening tests that we have available right now, are these things. So mammography for breast cancer screening, Pap smears and HPV testing for cervical cancer screening. Colorectal cancer screening can come through a stool-based test or a colonoscopy or even a CT colonography in some settings. For lung cancer, we use low-dose CT scans, and prostate cancer PSA testing has a role for certain populations to help find cancer earlier, when again, it would be hopefully more amiable to treatment, or treatments are more effective. But there's barriers. So there's barriers really at all levels. That's really, maybe easy for me to talk about on a slide and not necessarily easy to do in an individual's daily life or within what we have as our current healthcare system here in the United States. So there's barriers really at the patient level, the clinician or system level, and the community level. These I think are important to think about, because these are opportunities to help to both overcome individually as well as to build good systems so that there's good supportive environments around people to overcome some of these barriers. So these are big things that really do impact our ability to do well at having a healthy lifestyle and reducing our risk of cancer. But that comes through education and awareness, which is where things like today come in, so that we can talk about what it means to have a healthy lifestyle and help maintain good behaviors that are part of our risk factor reduction. Concerns about costs and lack of insurance go kind of across the board. I mean, that's a big deal. It's been impacted by the pandemic on lots of levels, including kind of where the economy is, also with employment and how insurance is tied to employment and those changes. So all of that matters and makes a difference. And then often not a positive difference, but a really kind of impactful negative difference when we think about access to cancer prevention. At the community level, I always like to mention that there's all kinds of barriers. And, in Cocoa, I think you live in a setting that's there's real geographic barriers, and that happens really across the country, is that it's not always easy to get to a setting where you can get the care that you need or get the screening tests that you need. And I like to think about the silver linings as much as we can, and maybe telemedicine and telehealth has helped break down some of that, but we still have lots of work to do to help make sure the right care is available in the right places, or that we help people get to that care if we just can't get the facility into every rural location across the country. So that's an important piece to this. And then I just like to mention, and I'll take responsibility as a clinician for this, is that our healthcare system is fragmented. We have to continue to do better so that patients have a seamless and well-coordinated experience with their care. So let me just close my last couple of minutes with some resources and things to do. So I've presented kind of a big problem. I've presented, what are all the barriers and issues around this. And now let me leave you with a couple of resources that I hope may help in your individual lives. So first is a campaign that we at the ACS started, I guess now it's been almost 2 years ago, called Get Screened, which was a public awareness campaign and act on social media and other places to help people learn more about what cancer screening is and how to get the care that they need. So this is kind of some screenshots of what the campaign has looked like. Importantly, the message is that cancer doesn't wait. Neither should you. We want people to get back on track, or get on track, maybe in the first place, with all of the recommended cancer screening tests as soon as possible. Which brings me to this, which is part of our cancer.org webpage. You see the link there. This is a downloadable kind of form you can take with you to your doctor's visits to help you start a discussion with your doctor about which screening tests you're eligible for based on your age. And the follow-on conversation to have with your doctor or other clinician is what other risk factors you have that may make you eligible for screening earlier. So family history is a big part of this, and other parts of your life that may make you a higher risk than kind of the average population. And then when we think about prevention, a couple other resources to leave you with. We have nutrition and physical activity guidelines for cancer prevention, which includes, recommendations about how much fruit and vegetables to eat in your day, how much fiber to do and include in your diet, how to maintain and reduce your use of alcohol and keep that very limited. And so that's all available on our website there. This is just a quick kind of infographic about how important nutrition and physical activity is, and how 1 in 5 cancer cases can be tied to excess body weight, poor or unhealthy diet, physical inactivity, and excess alcohol consumption. So that's pretty compelling and inspiring, even though I know it's not always easy to maintain a healthy diet, but we can all work at that on a daily basis. And then lastly, and perhaps most importantly, for people who may be still smoking, the smoking rates in the United States of commercial tobacco are lower than they've ever been, I would say. But certain parts of our communities and population still tend to smoke at high rates, and smoking is and remains the leading cause of cancer. It's a highly addictive drug that has been marketed in really, I'll say insane, unfair, and unjust ways over the decades. So this is a tool, a tailored email program that we've just launched called Empowered to Quit. It's very easy to use. You sign up and set a quit date to quit smoking, and you'll get some emails delivered to your inbox that will help walk you through your quit journey and support you. So that's really available on our website. Please share that with your friends and family, or take advantage yourself. I hope that could be helpful to you. So thank you so much. We are delighted to be here today. I think we'll have some time for discussion and Q&A later on. And here's my email address if you ever need to get in touch. Thank you.
Well, thank you so much, Dr. Makaroff. I suspect you could probably speak, for hours on end on just all of the resources and taking us on this journey on what is in place, but acknowledging and taking us in the journey of what we can do to really, address the issue. So thank you so much for being here. Next up, we're going to transition over to Melissa Buffalo. Melissa is the CEO of the American Indian Cancer Foundation. Ms. Buffalo received an MS in Human Development from South Dakota State University and has over 15 years of experience working in the public health sector in a variety of different roles. She brings a wealth of knowledge to the American Indian Cancer Foundation and is committed to working with and for tribal nations and urban and rural tribal health communities with opportunities to heal emotionally, historically, spiritually, and physically from the inequities of cancer. Her responsibilities as the CEO of the American Indian Cancer Foundation really include the overall direction and implementation of a strategic vision to improve Indigenous cancer outcomes nationally. And so today, Ms. Buffalo will be speaking on the impact of COVID on cancer in American Indian communities. So please welcome Melissa.
Thank you so much, Coco, for that introduction. Hello, everyone. How ampatuaste Melissa Buffalo Imachiapie, Nichincha Nu Myunke, Kanji Wakpa Oyanke Na Meskwaki Hematahan. Good afternoon. Happy New Year. I'm so honored to be here with all of you today. I want to thank Mayo for including ACAF in this important conversation. Honored again to be here alongside some wonderful panelists as well. And again, just want to thank Coco, our health equity manager here at ACAF, for moderating today's panel. Again, just here to, excited to talk with you all about the impact of COVID on cancer in American Indian communities. Just kind of want to start by providing a quick overview of the American Indian Cancer Foundation, some data on American Indian Alaska Natives, give a little preference to Indian Health Service, COVID and cancer, and then all the in-betweens, right, with delays, racial misclassification, resiliency, barriers, and just, again, ending also with some resources and some upcoming events that we have as we are in Cervical Cancer Awareness Month. So the American Indian Cancer Foundation is a national nonprofit organization that was established to address the tremendous cancer inequities faced by American Indians, Alaska Natives, and Native Hawaiians. ACAF was founded in 2009 and became operational in 2011. I love that our footprint continues to expand as a national organization that is housed in Minnesota. We really do strive to be that trusted partner by both tribal and urban community members, leaders, healthcare providers, and others working towards effective and sustainable cancer solutions. And the mission we have at ACAP that we really do our best to try and strive for is to eliminate, or how can we eliminate those cancer burdens on American Indian families through education and improved access to prevention, early detection, treatment, and survivor support. And then our vision, right? Through hard work, culturally appropriate, community-based programming, and policy change that affords Native people access to the best prevention and treatment strategies, we really do see a day where American Indian communities are free from those burdens of cancer. And again, what is that approach, right? How do we do that work? How is it meaningful? We're really here to work with in partnership with those tribal communities, those tribal clinics, those healthcare systems, researchers, and others to really provide the necessary and culturally tailored tools to address, right? We heard a little bit from Dr. Makaroff about some of those screening rates that are low. You'll hear about that in this presentation, and again, really understanding those barriers, but also, how does that cultural wisdom, that community wisdom, how do we use that to reduce those health inequities and really increase the health and well-being of our relatives? Because we do have that wisdom to find those solutions to those health inequities, but oftentimes some of those tribal communities, urban communities, are seeking organizational capacity, expert input, and then possibly resources. And again, what is American Indian? What does it mean? How do we look at it? How do we view it? Again, just context, right? There are 574 federally recognized tribes across 35 states. And so that's so much diversity, right? Between those 574 tribes, there's so many different cultures, traditions, languages, that connection to land, just, looking at these tribes across 35 states, there's just so much diversity, even geographically. And then again, just some context of what is our population, right? In 2020, the census, has that 9.7 million people identified as American Indian, Alaska Native. Again, that's roughly 3% of the population. And, sometimes that number might seem small to researchers, to folks doing data, but for Native people, to us, that 9.7 million is huge. And so how do we really look at getting data that is specific to our communities, that is up to date, that is classified accurately, and is beneficial as we bring those numbers back to our communities. And again, Indian Health Service, provides, care to our tribal nations. It is funded through the government. And again, looking at, what does it take, right, to fund some of these? And so in 2021, only 13% of the needed funding for Indian Health Service was budgeted. That's a small number. So 13%, which again is about $6.2 billion, was budgeted in 2021. And then again, context to the IHS provides care to about 2.6 million American Indian Alaska Natives across 25 states of those 35. Again, and so looking at this map here really shows again where these tribes are located. IHS breaks it up into regions. And so a lot of these Indian Health Service clinics do not have the necessary tools to screen, right? They have to refer out. So what does that referral out look like? What is that care? How do we get those patients out and referred to get in another door to get that timely screening, to get that treatment? What does that coordinated care look like? It requires that purchase referred care delivery. So IHS can, refer these patients out. And so this is just a map of some of that. And as I was looking at this and kind of, trying to finalize this presentation, I had to text one of my best friends who used to work for IHS. I was like, why is South Carolina, which maybe has a handful of tribes, very small population, like, why is it all blue? And she's like, that's a really good question. It's like, oh, cool. Like maybe we won't know the answer, right? Well, it's understanding that one of the tribes in South Carolina agreed, with getting their land back to provide care for the whole state for eligible IHS patients. So that is why that whole state is in blue, which I thought, I learned something new, which was very helpful. Okay, so some numbers, right? Again, we all heard those numbers, right? There was about a 9.4 million deficit in cancer screening at the start of the pandemic. Many of us have seen these numbers, right? We know the work that we all need to do. We see that drop in screenings. We've seen reports and data suggesting, right? Also that these numbers are returning to normal, while understanding that normal was not our normal in American Indian communities. So that is, why ACAF exists. And, oftentimes when cancer is diagnosed in our tribal communities, it is at a later stage, which then limits, treatment options, again, seeing barriers across the continuum. And so again, thinking about that delay in screening in those, how do we get them through the door to get screened for said cancer, right? And a lot of this comes, from personal stories too. I can also share, when my mom was diagnosed 12 years ago, she passed within 3 months. And so again, how do we, help our relatives get screened on time, and then the pandemic only exacerbated that number. Again, seeing that life expectancy, and I think we've read about when do they start to worry when that life expectancy number drops, right? They worry when it's about the measures, I think it was reading about tenths of a year. Well, American Indians lost nearly 7 years. And this drop really erases that equivalent of more than 4 decades of American Indian life expectancy gains, right? And so also reading that the average Native American person, looking at that number for 2022, is 65 years old. That was the life expectancy of the average American in 1944. So just, as I'm doing this, just been some really shocking numbers, right? 65 is not that old now that a lot of us, I'm 44. And so I look at that number and I look at my dad who is 72. So again, there's so much work to do and so much like shock value and things that again is like, what are we doing yesterday to really help this work? But then we look at the opposite side and we see those numbers that, the COVID vaccination rates for Native Americans were higher among Black and Hispanic Americans, based on CDC data. American Indians, really had access to some of the vaccination options. The numbers are higher, but yet we still have some of the highest rates of death, since the pandemic. And so again, how do we look at that? How do we take that information and move it forward when we're looking at not only cancer screenings, but also overall health equity? The next slide again just shows some of these leading cancers for American Indian and Alaska Natives, liver, stomach, kidney, lung, and colorectal cancers, again, consistently elevated across those several regions of that map I showed you. And again, let's go back to those numbers, right? Thinking about that, only 13% of the funding was given to IHS to really, how much to really fulfill and be able to provide all of the work. And we know that a majority of our IHS facilities, unfortunately, do not offer the cancer screening. So again, having to refer out. And again, just emphasizing that IHS is not health insurance, right? And so that coverage of cancer prevention services such as screening, again, are not guaranteed under Indian Health Service because it's not health insurance, right? It's not primary care, and it was not the provisions of the Affordable Care Act. And also, IHS patients, about a third of them are uninsured. So again, when we look at all of these factors, and we understand why there is a high prevalence of chronic health conditions and health disparities within our tribal communities. Right, so again, COVID and cancer, what was some of that disruption in our health services at the head start of the pandemic and probably continue today, right? Oh, yes, there we go. Thank you, Kylie. Again, what was that postponement of those appointments for the cancer screenings, the delay, even the canceling of them, or not even following up on them? Possible delay, right? You might have got a screening, but also delay of follow-up of those abnormal results. Are you listening to those symptoms and ignoring them because of the pandemic, which also then leads to a delay in treatment. And we know that the COVID-19 pandemic created that disruption of health services. for millions, not just American Indians, but millions, right? I shared that number at the beginning. And so again, even Dr. Makaroff talked about it, right? Those consequences, that interruption in care and diagnosis and treatment, we'll see that as the years come. So again, how do we lean on, what are the tools, the resources? How can we help those numbers come back up, get up within our tribal communities as we move ahead, right? And so again, how do we move past those delays? How do we work in partnership with one another? One thing again about the IHS this year, for the first time ever, received advance appropriations for IHS, which means that when there is a potential government shutdown, that IHS will not shut down, right? And so this is historic. This has never happened, right? It, again, will protect those health programs within IHS to continue to provide care despite a potential government shutdown. And again, seeing what IHS, has done and how they've responded to the COVID-19 pandemic, getting those vaccinations out. Was recently came across a study through the American Society of Clinical Oncology that did a survey on COVID-19 and oncology registry. The aim was to really help the cancer community learn more about the patterns of symptoms and severity of COVID-19 among patients with cancer. Again, and then also seeing, how did COVID-19 impact the delivery of cancer care and patient outcomes? And so reading some of the outcomes and, reading what the epidemiologist found, one of them observed that among American Indian Alaska Native patients living in rural areas, 75% of those patients experienced a treatment delay of 2 or more weeks, right? And 37% had care discontinued or canceled, 37%. And so again, she noted, yes, there is a small sample size, right? But this again warrants the need to continue to research, to investigate this. And so when I went into this study, you could click on their dashboard, right? And I was like, let me go look at these numbers. Let me look a little further. Well, there was no American Indian Alaska Native option. It was either other or unknown. So again, getting back to those disparities, those inequities, where can we address them? What is within our realm, right? And that is racial misclassification. How do we help eliminate that so that we have that data to make these choices so tribal communities, tribal clinics can make informed decisions for the health and wellness of their patients. So again, how do we move ahead, and what has ACAF's role been as we've did our best to stay the lane of understanding the cancer disparities, the health inequities during the pandemic, the delay in screenings, but also doing a little bit to pivot at the pandemic. So one of our bigger campaigns was to be a good relative, right? And that's what it means to be Native, right? We are always good relatives. That is something that, is not spoken, but we just know how to do. Taking care of yourself and others, right? Knowing that you got vaccinated, to take care of somebody in your family, to protect them, right? It wasn't necessarily for you. For me, it was understanding, right? If I get the COVID-19 vaccine as a single mom, I'm protecting my kiddos. Protecting my dad who's in a nursing home. So again, coming from that perspective as Native people and really, pushing that. And we saw other urban and Native organizations really come with this theme as well. So it was nice to see that consistency across the board. Another thing we did was, emphasizing too that you can get your cancer screening during the pandemic. What are some of those things? Masking up, again, reemphasizing some of those cancer screening recommendations, the ages, the symptoms, how you can have a conversation with your provider. And this resource on the left is, our lives are sacred, and understanding that drop in colorectal cancer screenings and how we get our relatives back. This resource on the right, Cancer and COVID-19, again, what are some of those screening guidelines for those screenable cancers? And what is the flow chart? Being able to ask this question, are you eligible? Do you have these symptoms? And then, what to expect at that appointment, or how those conversations can be had with your provider. Because again, how do we address that low number of screening, the lack of timely access to screenings, to affordable care for our American Indian populations? And again, how do we do that in a culturally tailored way? Again, it's, how do we get back to promotion not only culturally tailored, but community tailored to that community, that these resources reflect, the community and are needed by the community as a way to educate and provide tools and resources. Again, just another resource on the next one that we created, during the pandemic, understanding what really goes into a lung cancer screening, understanding the myths or the barriers to, is it a process? Is it a day-long process? And so we currently are working on releasing a video that we did in collaboration with the Native American Community Clinic, where Dr. Anthony Stately actually went through a lung cancer screening. And so seeing him go through and experience a low-dose CT scan and kind of seeing those results in a 90-second PSA, was helpful, because even for some of us, of understanding step by step of what goes into a lung cancer screening and who is eligible and why you should be thinking about this screening. The next slide again, Dr. Loretta Christensen, Chief Medical Officer with IHS, was reading one of her journal articles that came out last year. And again, emphasizing, right, we understand the disparities, before the pandemic, during the pandemic, post-pandemic, whether or not it's cancer, diabetes, suicide. And so seeing this in this journal article for me was just like, yes, right? The strength and resiliency of American Indian and Alaska Native communities in the effort to become vaccinated is inspiring. Again, taking it back to that protection of the community, being a good relative. And so again, emphasizing that American Indian and Alaska Native communities led the country in early vaccination. And again, it shows that they remain the most vaccinated of all racial and ethnic populations. Again, emphasizing those values, right, as Native people, as family, and just trusting their leadership, right, and seeing where IHS responded to that, and to really drive that willingness for our communities to get vaccinated, and providing the knowledge and the understanding that goes with all of that, because we know there's mistrust in our healthcare system. There's mistrust within IHS. We know that a lot of American Indians have personal experiences with that. So again, just kind of wanted to end on that, but also again, we are in Cervical Cancer Awareness Month, so wanted to share some of the things that are happening this month, but just emphasizing again that resiliency that our communities have, and that is what, for me is a driver and continues to help me do this work on a daily basis. We honor this month by, calling it Turquoise Thursday, an opportunity to raise awareness for cervical cancer screenings, also HPV vaccination. So we recently, created a new pledge, right? What does it mean to pledge to say you're committed to that screening? And so there's options. It's a Google form. I will get that link over to Kylie, because I don't think I gave you that link, Kylie. And so this one just really is, honor your body by committing to getting screened. And so you fill out this Google form and then you'll receive it via email. I do want to share that on January 26th at 1 p.m., our staff will be hosting a conversation and sharing updates on the HPV vaccine with Dr. Kathy McLaughlin and Dr. Alyssa Larish, both with Mayo. And so I know Kylie was going to put that link in the chat. And then just quickly, one more slide, two more resources that came out recently. And I think, Kylie, you do have that link as well. The one on the left, I know this is very hard to read, but again, understanding what goes into a PAP test, right? Why you need one, what does that mean? What are you doing for your body, right? What are those results? What is the conversation you can have with your provider? But also, understanding, again, what does it mean to culturally tailor a resource? So in this one, we did include some words in the Lakota language. We also have options that are not in Lakota, so tribes can use and adapt these and, use their language as appropriate. And so again, this is, ways that we really try to bring this information back to our tribal communities in a way that is community tailored and culturally tailored. Next slide is, again, just ways to reach out to us, follow us on social media, visit our website, which I will say is under Some Repairs. So if you can't find the link, reach out to at acaf.org. Our info at acaf.org, and we'll get that information, our resources over to you. I just want to say thank you, Kitabi, for allowing me to be on this panel.
Thank you so much, Miss Buffalo, and really sharing these images and, talking about the resiliency. And when we think about, why we're doing this work and thinking about, increasing screenings, all of these personal stories and connections are so important. And I think you really said it here. It's really focused on helping our relatives. So thank you so much. Now we're going to transition over to Dr. Katherine Price. Dr. Price is an associate professor of oncology and tumor group chair of head and neck medical oncology in the Division of Medical Oncology at Mayo Clinic in Rochester, Minnesota. She graduated from Mayo Medical School in 2003 and completed her internal medicine residency through the Mayo Graduate School of Medical Education. After her oncology fellowship at Memorial Sloan Kettering Cancer Center, she returned to Mayo Clinic Rochester as a head neck medical oncologist. In addition to her work in oncology, she is a diversity and inclusion leader for medical oncology and is co-leading the efforts in the Midwest to decrease health disparities and increase access to cancer clinical trials for minority and underserved populations. She has a specific interest in promoting education and awareness for the HPV vaccination and is working with local and regional healthcare providers and community groups on this effort. So we're so excited to have Dr. Price with us to elaborate more on the HPV vaccine. So please welcome Dr. Price.
Thank you, Coco, and thank you, Kylie, for the invitation. I'm going to go ahead and share my screen. All right, so thank you again. It's quite an honor to be here and be part of this panel. Over the next 10 minutes, I'll just cover some basic information about HPV, some information about the HPV vaccination, as well as look at some of the current national and regional vaccination rates. Touch on a couple of disparities I think are emerging and important in HPV vaccination, and finish up with my perspective as an oncologist. So most of us probably know, but HPV stands for human papillomavirus, and everyone is at risk for this infection. Why does it matter? HPV vaccination can prevent cancer, and HPV is a virus that leads to the development of certain cancers that we'll talk about, and these cancers can be life-limiting, but certainly can be life-changing. HPV is spread primarily through sexual activity. And I think it's important to note that really any individual who has been sexually active at any time is at risk. So even having one sexual partner doubles the risk of HPV. And so truly this is a problem for all of us, not just for those who might be deemed at higher risk for having higher numbers of sexual partners. What cancers are caused by HPV? I think the awareness surrounding HPV has been historically focused on females, and HPV can cause cervical, vaginal, and vulvar cancer in females. But it affects men as well. So for both males and females, HPV can cause anal cancer and can cause head and neck cancer. So these are the cancers that I treat. And the part of the head and neck that is caused the part of the head and neck that can be affected by HPV is what we call the oropharynx. So it's the tonsil or the back part of the tongue, the part of the tongue that you can't see if you look in the mirror. I think one of the messages that I found, is not necessarily conveyed is that boys and men are at significant risk for HPV, and for head and neck cancer caused by HPV virus, it's actually men that are significantly at higher risk compared to women. So very important to vaccinate our boys. This is a graphic just depicting the actual numbers of incidents of cancers caused by HPV. The purple dot is precancerous lesions in the cervix. But if you look at the remaining dots, you can see that oropharyngeal cancer or head and neck cancer accounts for the single largest group of HPV cancers that are diagnosed. And as I mentioned, these are more common in men. Just a brief history of the vaccine, which is always interesting. Work on this began back in the 1970s with Dr. Surhausen, who was a German virologist. And he identified in the 80s that HPV 16 and 18 DNA could be found in cervical cancer. And actually work on the vaccine began in the 1990s. In 2006, the FDA approved the first HPV vaccine for girls ages 9 through 26. And then in 2009, it was recommended that boys get vaccinated as well. In 2014, we saw approval of Gardasil 9, which is the currently available vaccine that covers a broader range of high-risk HPV subtypes. And then a couple of years ago, in 2018, the FDA did expand the use of HPV vaccine through the age of 45. I think bringing up the timeline is really interesting because one of the concerns that we heard during the COVID pandemic about COVID vaccination is that, oh, it's so new and how do we know it's safe? And a lot of hesitancy surrounding that. But if we look at HPV vaccination, it's actually the opposite. You know, this was a long time in the making. This is a vaccine that's been available for decades. Millions of doses have been administered, and side effects, if any, happen are extremely mild. And there's a very, very low rate of serious side effects, less than 1%. So I think we can be confident in reassuring our family members, our friends, our patients, whoever we interact with, that HPV vaccination is very established and very safe. This is a summary of the current guidelines for HPV vaccination. It is part of the routine immunizations recommended for all boys and girls at the age of 11 and 12. It is strongly recommended through the age of 26, and as I mentioned, there's approval now through the age of 45. You can have this vaccine as early as age 9, and if you get the vaccine series by the age of 15, you require 2 doses. If you get it at 15 or later, you require 3 doses separated as listed here in the table. One of the messages is, you know, the earlier the vaccine is given, the better. It doesn't mean that you should not get it. If you are older than 11 or 12, you should absolutely get it if you still fall in the age range for recommendation. But early vaccination does translate into less cancer. This is a graphic of that was demonstrated a couple of years ago in the New England Journal of Medicine. So this is a graph that shows in the green line here at the bottom. So this is the diagnoses of cervical cancer as people get older. So you can see that there's a very, very low rate of cervical cancer in those who are vaccinated at a younger age, less than age 17. The orange line are the unvaccinated individuals. So that's, you know, a fairly steady increase in cancer diagnoses over time. And in those that were vaccinated at an older age, over age 17, it did decrease the number of cervical cancers, but there were still some that developed. So the earlier, the better. The Office of Disease Prevention and Health Promotion has set a target nationally that we want to vaccinate all of our adolescents, 80% of them. That's the target. So where do we stand with that? This is data that comes from an annual survey about vaccination in the United States of adolescents ages 13 to 17. And you can see highlighted here a couple of numbers. So this middle dotted line here, so this is the percentage of adolescents that received at least one dose of the HPV vaccination. And you can see that that's at about 75.1%. The number in parentheses is the year prior. So we are slowly making some progress. The bottom curve here is the percentage of adolescents who had a completion of the series. So they received all of the recommended doses, either 2 or 3, based on their age. And you can see that that is just over 58%, also improved from prior years, but both of these are still below that target of 80%. Interestingly, if you compare it to the graphs here above, which are looking at other routine vaccinations that are given to adolescents, you can see that there is a hesitancy surrounding HPV vaccination. So even among individuals who are getting vaccinated, there's still a hesitancy about giving the HPV vaccination, and that's a complicated issue that has lots of different reasons for it. If we look at those national rates on the left summarized, and then for our rates here in the Midwest, specifically for Mayo, you know, we're not doing as well as we should. We're only vaccinating just over 50% of our patients by age 13. And then as you get into the higher years, that number drops off quite a bit. expanding that lens a little bit to regional vaccination. Minnesota does pretty well compared to some of the states surrounding us. But you can see for, up-to-date HPV vaccination, no state yet in the Midwest area here has reached that national target of 80%. One of the important disparities that I alluded to a little bit is related to gender. So if you remember back to the timeline that I talked about, the vaccination for HPV was originally approved and recommended only for girls, and then a few years later, boys were added. But that has resulted in some unclear messaging and unclear understanding of who needs the vaccine, and it really is needed by both boys and girls. So you can see over the years, whether we look at receiving one dose or up to date, if you compare kind of males to females, there's a consistent lag in the percentage of males being vaccinated compared to females. That is slowly improving over time as our vaccination rates are slowly improving over time, but there still remains a disparity. Geographically, we can see trends in disparities in HPV vaccination. So the states that are green and yellow, so this is primarily in the South and Southeast, have the lowest rates of vaccination compared to the upper Midwest and the coasts. And going along with that, incidence of HPV-associated cancers mirrors that trend in vaccination. One of the really important disparities that I think needs some attention is the difference between vaccination rates in rural versus urban areas. So this was some data that was looking back actually at, about a decade ago, where there were really quite dismal rates of vaccination, particularly for boys in very rural areas. You can see on the right, rates as low as 5% in isolated small rural and small rural towns. Fortunately, things have gotten a little bit better, and this is a busy slide, but I just want to highlight over here on the left. So what we have here is progression from rural areas to more urban areas, and then males to females going up. So if we look at the males here for HPV up to date, if you look at rural areas, they're reporting a 48% vaccination compared to 57.8% in urban areas, which is still slightly below the rates of female vaccination in rural at 50.3 versus 63.2 in urban. So things are getting better over time, but there remains these disparities between gender and rural urban. Why does this matter? Well, this is something that's near and dear to my heart because we're seeing rising rates of oropharynx, head and neck, or throat cancer in patients in rural areas that are HPV associated. In urban areas, the numbers are still increasing but leveling off, but we're seeing a sharper increase in rural areas. And so with this, increase in head and neck cancer in rural areas and our lagging vaccination in rural areas, we really do have this existing and growing disparity that does require fairly urgent attention. So, I think, some of the key messages as there's a lot of information in this town hall, which is great. What I'd want people to walk away from is that really everyone is at risk for HPV infection and that HPV can cause cancer. We do have a vaccine to prevent cancer. It's the only cancer prevention vaccine that's out there. And the earlier the vaccine can be used, the better. I, think that I have a unique perspective in this because it's often hard when we have something that develops over a long period of time. So if we look at, most individuals are going to be infected with HPV earlier on in their life when they're teenagers or young adults. But it takes about 30 years for somebody to develop a cancer related to HPV most of the time. So that's a really long time. So there's a bit of a disconnect where a decision that we make when we're younger, we don't necessarily think about what the implications of that. I have the fortune or misfortune, I'd say, of seeing the end result of that. So I see patients every single day. 70% of the patients that I see in clinic have a preventable cancer with HPV vaccination. And treatment for head and neck cancer is really, really hard. And our patients go through a lot with surgery and radiation and chemotherapy. And, many of them can be cured, but not all of them. So we're looking at a lot of suffering and unnecessary loss of life across the age spectrum, both men and women. So I would like to put forward just that this is a really incredibly important issue. And we, can prevent these cancers, which is tremendous. I think if we look at lung cancer and breast cancer and prostate cancer and some of these cancers that have a huge burden on our population, we would be ecstatic if we had a vaccine to prevent those. And here we have one that's being underutilized. So I encourage you to be an advocate for HPV vaccination for your loved ones and anybody that you have influence over. It does take a village. I think this is a sticky issue. Vaccination is sticky. There's lots of different barriers, from individual level to systemic level, so it is tricky, but it doesn't mean that we should shy away from it. And, I've found that often it's those individual conversations that I have with people that really, starts to shift perspective. And so if you have opportunities to be that advocate, I would encourage you to do so. Please feel free to reach out to me. My email is here at the bottom. I'm happy to answer questions or help with this effort in any way that I can. And I thank you for your time.
Thank you so much, Dr. Price, for just your expertise and the heart and the compassion, because that takes a lot to deal with all of those. And we just really appreciate, your leadership and the work that you do and continue to do. And I think you summed it up at the end. It just, it does take a village. And I think all of the wisdom that's been shared so far on this call is really, exhibiting that. So thank you so much. So next, what we're going to do is we have a presentation video from Crystal Lammers. It's a breast cancer prevention story. Crystal is a mother, a grandmother, a sister, an aunt, and a caregiver of cancer patients. She was unable to join us live today, but recorded the following message for us to share with you all. So we're going to switch over to the video from Crystal.
It's Crystal Lammers. I am here to talk about breast cancer. I found out when I was 45 that my biological mother had breast cancer, and many people in her family plus her died of breast cancer. And so I have always been really good about getting mammograms, but as soon as I found that out, they decided that every 6 months was a better thing for me for mammograms instead of every year. And so I work with Dr. Westby, Northeast Clinic in Rochester. She has been really good about helping me keep on task with things like that. And I just really feel that mammograms are very important and stuff, whether you have cancer, breast cancer in your family or not, they're very important. They're a good tool to keep you on top of things. They can find things sooner. My doctors would like me to do the 3D thing, right, over imaging for breast cancer, but my insurance doesn't like to pay for that. So I'm still working on that because they would really like that done. It's been a while since I've had that done. So I'm still working with my insurance on that, and hopefully they'll allow that to happen this year. But so when I found out that my mom had breast cancer and then many of the members of my family on that side died of breast cancer, it left me a little concerned and stuff. So I try to keep on top of all that. Also, I try to eat healthy. I exercise all the time and stuff. I try to stay active in that. And I think it's a good idea just to talk about, breast cancer and how it affects you. And if you have any questions, your doctor is a good person to talk to because they have resources that I cannot get a hold of and stuff. And they, can help you along the way. And two, when you talk to people about breast cancer, maybe they've been through something that they can, help you with too. And it makes you feel like you're not alone when it comes to breast cancer, because it is a very, very, very scary thing. I take care of people that have had breast cancer, have passed away from it because they just didn't decide to do a mammogram and they didn't do the preventive things that you can do to help you get through it before it gets out of hand. So I think it's a good idea to talk about it, and so that we're not feeling like we're by ourselves. And I guess I'm a mother, a grandmother and stuff, and I have girlfriends that have been through breast cancer. I have a girlfriend right now that's going through breast cancer. So I will help her with her journey also. But we just need to talk to each other, keep each other posted when it comes to things. I mean, it's okay to talk about it and stuff. I think it's wonderful that we can talk to each other about it so we can keep each other where we need to be when it comes to breast cancer, because it is something that you can survive as long as it's caught on time. So that's all I can think of. Thank you for your time, and get those mammograms. They're very important.
We appreciate Crystal's time and her wisdom and taking that time to share with us. And, I love what she just said, talk to each other, right? Be engaged, because I think that makes a difference. And hearing too, a lot of what's been shared around, just the unknown and what that looks like. So, I think she put it so sweet and succinctly. Now we're going to transition over to just sharing some resources that exist. And thank you, Kylie, for sharing your screen. I think in the day that we're in with social media and all the hashtags, right? Today, the message that we're leaving with is really get screened, hashtag get screened for cancer. And so some of these next resources that are available, we'll just kind of go through some of them. And Kylie, please feel free to jump in at any time. But within some of the states, there are free or low cost screening programs. You can check on the national level on this website, freemammograms.org. There's programming within Arizona, Florida, and Minnesota, and there's some specific resource and numbers that you guys can all check there. So if you want to take a moment, screenshot, write down, just encourage you all to explore what does exist within your communities, within your state, within your regions. I know Dr. Makaroff had talked about, I live in a very rural community, so we do have our local clinics, but majority of the time we have to drive either 2 to 5 hours to get some of those screenings. So it's very important to just kind of be aware of the resources. Also, the Mayo Clinic has a comprehensive cancer center, and where patients have access to screening, treatment, different patient education, culturally specific patient navigators, as well as clinical research trials. So you can find more information about these programs within Arizona, Florida, Minnesota, and there is a link below. But I just think that there's just a wealth of knowledge here, and I really appreciate having those different type of culturally specific patient navigators as well, because it makes a difference in thinking about like how we build trust and what that all looks like. Next, please. Another great resource too is the cancer-related clinical trials, and just being a family member, I am so grateful for these trials as they're helping my relatives go through their own journey. So there's constant ongoing research to improve cancer screening and treatment at Mayo Clinic. Volunteers are an integral part of this research process. People with particular diagnosis, as well as healthy people, can both play a role in contributing to medical advances. And so really without the volunteers, these studies would not be possible. So people who volunteer for clinical studies, there are a variety of reasons. They may have a desire to improve medical care for future generations, a connection to certain diseases or illnesses, whether it's through personal experience, through friends or family, as well as just a personal interest into science. As a mother of 4 kiddos, we constantly talk about, what that looks like for their own relatives, but thinking about the future generations, because our goal, right, is to live in a world where we're not affected by cancer. And so if you want to get more involved and learn more, there's a number there as well as a website. So if there's any questions, or Kylie, if you wanted to add anything to some of these great resources, please do.
You did a great job, Coco. Thank you.
Thank you, Kylie. So now we're going to ask all of our panelists to turn their cameras back on and really take a time for some Q&A. We do have some questions in the chat. So thank you, Dr. Makaroff, for answering one of the first questions. And Kylie's, okay, so I'm just going to go to the ones that we have open. The first question is, will this recording be available after the webinar? I think that's the $1 million question after every panel. I believe so. Thank you for very informative. Another question we have from Panita Pratcher. If somebody would be able to define the minority population and underserved population, what is the difference and what is the commonality? So I'm just going to open up to whoever would like to answer that question.
The question, let me just make sure I understand the question, and maybe Melissa, you want to chime in after me. I think I heard the question, Coco, about the difference between a minority population versus underserved population. Is that the question? So, okay, so here are my thoughts. I'm not sure that I would call this a definition, but here's my perspective on the way that I kind of think about those characterizations. I would think about minority populations as being like some characteristics that isn't the majority, which may or may not mean that someone fits a category of underserved. I think those are kind of two separate things. They often overlap, and probably the part of the circles that overlap are pretty big. But I try to keep in my mind the differences there to understand that somebody can be underserved in some way and still fit into a majority characteristics of some kind. But many people who fit a category or characterization or part of a population that would be a minority population often also falls into that category of underserved. So that's the way I kind of tend to think of it. But I would love to hear what others think. That's a very good question.
I was going along the same as you as we think about underserved versus minority, racial and ethnic minorities. So I think you covered it. If Panita wants more definition, maybe we could ask if there's another follow-up question, but I thought you answered it the way I would, Dr. Makaroff. Dr. Price, I don't know if you have anything to add.
Yeah, I mean, I think it's a difficult issue. And, I feel like the rural populations are, a good example because, in a lot of studies and a lot of times when we're talking about underrepresented minorities, there's a focus on, Black population, Hispanic, Native American, Native Islander, and there's very specific definitions like that. But in the rural area, there's a lot of underserved people. They might be white, but they're underserved, or they don't have access to healthcare resources or different things. So I think it is really tricky. And you want to include everybody and not exclude everybody, and not make assumptions. So I think the language is really hard. I think when we try to look at it here, I like to think about it as just trying to define in a broad sense. Are there populations that are disadvantaged? Are they disadvantaged because of where they live, or because of their, economic status, or because it's historically been a population that, has had a lot of disparities and not had the resources and opportunities? But it is really tricky. And I think, it's also very, regional and local, you know what I mean? I don't think there's one definition that fits.
Yes. Thank you so much. We're going to jump into our next question. Is the HPV vaccine effective even if one has had HPV?
Yeah, that's a good question. So I think yes and no, meaning, so the HPV vaccine that's out there is not a treatment vaccine, so if you were infected with the HPV vaccine, it's not a treatment for that. Now, most adults have been exposed to HPV. Most adults also clear that virus. So they're exposed and then their immune system takes care of it. But a percentage of the population, probably about 10%, do not clear it, and they go on to be chronic carriers of it. And then those are the groups of people that are at risk to develop cancer from it. So, but the vaccination that's currently available, covers several different high-risk types of HPV, as well as low risk that will cause genital warts. So you could have been exposed to one subtype of HPV, but still benefit from the vaccine because you're getting covered for other types that you haven't been exposed to yet. So there's really no way to piece that out for an individual. I encourage everybody to get vaccinated, even if, they may have already, had an HPV exposure, because you are potentially covering other subtypes, that would not have been covered before. And we do see, in the head and neck cancer world, I don't know if this is true for cervical cancer, but sort of a two peaks in when we see cancer. So the first, peak of the HPV head and neck cancers happened kind of in the mid 50s related to exposures earlier on in life. But we also are seeing a second peak in, people who are in their kind of 70s and 80s. And that's probably a whole separate wave where, individuals may have been married for a long time, and then their spouse dies and they remarry or become sexually active again in the middle part of their life. And then they're developing cancer, in their older years. And so I think, vaccinating, is just a way of trying to, cover your bases, because we don't know what the future holds for any of us.
Thank you for that question and that response. Our next question is, how can rural areas or states that are less populated make an impact on vaccination rates? Providers are hard to reach and not always interested in receiving new information.
That's also, really, really hard question. And I guess if we think about it, I mean, there's no obvious right answer or right solution for everybody, but I think, we have seen, certainly there's a lot of misinformation and misperception about the HPV vaccination, even among healthcare providers, so we know that providers still can go in with their own biases. They might think, they might be only recommending it for, individuals that they perceive as being at higher risk, and maybe, not recommending it for both boys and girls. So there is a discrepancy there. So, and certainly we would hope that, as that providers would be open to new information, but I think that, it comes down to the individual and advocating for yourself. You know what I mean? I think most providers, even if they don't know that much about HPV vaccination, if a patient is advocating and saying, this is important to me and this is something that I want, would probably be able to get that. The other thing is, I think, and it's been shown too, if you have, vaccination, if you have to capture people when they're there, if they're in the clinic for something else, you know what I mean, to try to still always have vaccination on the radar, because they may leave and not come back again for a couple of years, and so trying to maximize whatever limited contact there is in the healthcare system, to try to, get the services when you're having that contact, and not assume that there's going to be opportunities to do it later. I don't know if anybody else has thoughts beyond that.
I think you nailed it. I think, again, the importance of public health information and, whose role is it outside the provider, but we also know how much emphasis a provider has on helping to build that trust and, say push said vaccine or what, but I think you nailed it.
Wonderful. Well, we just thank you all so much for your time, your wisdom, your energy. I think when we think of the leaders in this work, and when we think of all of the ongoing, we just really appreciate what you brought to this table today in this virtual circle. I feel like you all could have went on for a few more hours each on your own. So just thank you again. We're gonna put up a link here. I know Kylie put a website link in the code, but if you want to just take out your phones and scan this QR code, and we really encourage you all to complete a survey on today's panel. So just first of all, thank you, Kylie, for this opportunity. Dr. Makaroff, Ms. Buffalo, Dr. Price, thank you for being here. And we hope you all leave today with just more facts and figures, and, encouraging your relatives to get screened, get vaccinated, or just even learning more of what all of this means for your communities. So with that, we will close unless there's any burning questions. We will see you all next time. Thank you so much for being here.